Dear lab members, good afternoon. It's a privilege for me to be in front of you. I'm thankful that you have welcomed me so incredibly well and allowed me to be a part of this lab and take part in the activities of the Department of Global Health and Social Medicine. This is the structure of my presentation. I will first introduce myself briefly and also introduce you to my sociocultural context. Then I will present the findings of some of the research regarding stigma and coercion developed by my colleagues and I in Valencia in Spain. And to conclude, I will end by summarizing the conclusions and future developments of this research. To start, I will tell you some things about me. As some of you know, I've been a mental health nurse since 2003. And here are the highlights of my academic and professional background. What I will highlight the most is that I combine teaching and caring as a mental health nurse in an acute care unit from 2005 to 2017. And in this period, I also developed my PhD thesis. And in 2017, I started my full-time academic career at university. And that's where I got the opportunity to research on some fields of mental health that are actually very relevant and my passion, which are stigma and coercion. In this area, I have always participated in, designed and developed studies with a small number of other researchers, and mainly with no funding. This is why the studies I am presenting are modest, but we always have been moved to be rigorous and make visible some of the problems related to stigma in our context and coercion and try ways to reduce them. Please contextualize this modesty and my imposter syndrome while I share them. This said, I will briefly introduce my context. This is Spain. It is a medium-sized country with a population of 48 million, located in the southwest of Europe. And we belong to the European Union since 1986. Politically speaking, it is a parliamentary monarchy. We have a king with a left-handed government now, and independent of the government. Before our parliamentary monarchy, we had a dictatorship. That's when these public services and government policies to help people with social problems were stated, but Spain has public services that are generally well preserved and a social security system that protects social rights, such as financial support for people who are on a sickness leave or who cannot work anymore, retirement or widowhood. We have strong universal healthcare and education systems, and they are the leading resources used by the main group of the general population. And that explains why most of the research I am going to present is developed in public education and the system of public healthcare. Now you know me and my context better. I will present a synthesis of the main pieces of research that my colleagues and I have developed regarding coercion and stigma, classified into 4 topics: stigma and physical health, stigma and therapeutic relationships, stigma and coercion, and fighting stigma with students. Apart from this, I have participated in other pieces of research with a bigger group of researchers focused on frailty and the care provided to people who have oncologic problems and also their caregivers. I will not tell you about them today, but I will happily discuss these subjects with you in another moment if you would like me to. Starting with the physical health of persons with mental disorders diagnosed, there is a hypothesis that a potential consequence of the stigma that we professionals have is that people who have a mental health diagnosis receive less attention from healthcare services. And we developed several studies to assess the situation in our most immediate context. It is known that people with certain psychiatric diagnoses have increased mortality rates, and these increased mortality rates are mostly attributed to natural causes, mainly cardiovascular disease and cancer. This is linked both to the nature of the disorders and also to the use of antipsychotic drugs. To start with, we measured cardiovascular risk in individuals treated with long-acting injectable antipsychotics through a cross-sectional study. in which we measured metabolic syndrome and the Framingham risk score. Our criteria for METs were the IDF, the International Diabetes Federation, and we measured blood pressure, waist circumference, glycemia, and lipidemia in the participants, who were 130 persons, 18 of which were men. And we found a high prevalence of metabolic syndrome as we expected. There was a 48.1% of men who had a metabolic syndrome, and this proportion was 42.9 among women. We compare this to the general populations in Spain, and it's around 30. We have the Mediterranean diet, but still we have it's not very low, but these are still higher. And we found that the Framingham risk score was also higher in the participants. We found that men had high risk of developing, Framingham risk score measures the risk of having a cardiovascular lethal event in 5 to 10 years. And we found that men had a high risk while women had a moderate risk. And we found that there were no differences related to the type of antipsychotic or the duration of the treatment that they were following. We said cardiovascular was one of the risks, and then we had cancer. So apart from assessing cardiovascular risk in persons diagnosed with mental health problems, we analyzed some aspects of cancer diagnosis and prevention. We worked with different samples. First, we focused on the secondary prevention of cervical cancer through screening. We know it's known that invasive cancer and its mortality have been dramatically reduced by primary prevention through the vaccines and secondary prevention through early detection. But the screening rates, we know they tend to be lower in a vulnerable group. So knowing that the Spanish cervical cancer screening rate for the general population was quite high, it's 80%, we wanted to know how this was for women who were diagnosed with a mental health diagnosis. And we developed a cross-sectional study, including women 25 to 65, which is the age, covering the mass population screening in Spain. And we recruited them from a psychiatric unit of a public hospital. We included 103 women with a mean age of 45.6 years, and they had a dramatically low percentage of coverage of this cervical screening. They have 27.2%, and including the last 5 years, because depending on the age, it is suggested to be every 3 years or every 5 years. We consider the most lax, the softer criterion, and still we found very, very low preservation. We found that per age groups, the women who had a better coverage were those who were 35 to 44 years old, and those with a worse screening rate were women 55 to 65 years old. We also worked on data regarding other 2 types of cancer that have mass population screening. These are breast and colorectal cancer. And in this case, our hypothesis was that knowing that people with diagnosed mental disorders have a worse cancer prognosis, not having more cancer prevalence, and this has been partially attributed to lifestyle, sedentary lifestyle, or tobacco, but also probably to a later detection. And we wanted to know what happened in our context. That is why we developed an observational retrospective case control study using electronic medical records, and we chose all the cancer diagnoses that had occurred in a period of 13 years in one department, covering 200,000 people. And we matched every case with 2 controls, matched by age, gender, and also diagnosis. We wanted to compare the severity of breast and colorectal cancers, the severity at diagnosis. And we found, with these 111 persons we included, that individuals with mental disorders had a higher relative risk of nearly 4, odds ratio of nearly 4, to be diagnosed with an advanced tumor state for both breast and colorectal cancer. I have to say that we did not do a separate gender analysis because most of the participants were women. So the data by gender would not have been very, very useful. So cancer screening for early detection and intervention in people with severe mental disorders must be improved in our context. And this could make us think of who could participate in this. And last but not least, regarding physical health, we were also concerned about the sexual health and sexual life of people who we care for. And it is known that there are associations between psychosis, antipsychotics, prolactinemia, but the precise relationships are not known. And also, the evidence we have comes from very restrictive studies. Most studies focusing on sexual dysfunction are based on people who are on monotherapy. And that is not at all the reality we find in the clinics, at least in our context. So we decided we wanted to study the prevalence of sexual dysfunction and hyperprolactinemia as well in a sample of people treated with long-acting injectable antipsychotics. It's not the same sample, it's a different one, and it's later in time. So we developed a cross-sectional study, naturalistic. We wanted to include anyone who wanted and who was on LAI. So we used interviews to assess sexual satisfaction, sexual dysfunction, and then we used blood tests to detect prolactin in men and women and testosterone only in men. And we found a high sexual dysfunction prevalence, which was around 62.2 for men and 51.2% of women. And the loss of libido was the main symptom, the most prevalent symptom. Hyperprolactinemia was also very frequent. We found it in 56% of the men and 61% of the women. And when we tried to find associations, we found that women in reproductive age did not have any specific interactions, but interrelationships. But men had, and men and postmenopausal women, hyperprolactinemia and smoking were related to the appearance of sexual dysfunction. But in men, also, the antipsychotic dose was important. We calculated, we included any antipsychotic, an LAI antipsychotic, and we translated this into milligrams of haloperidol to do the calculations properly. And so these are studies in which we focused on physical health and well-being, confirming the disparities between the general population and the persons who have a psychiatric diagnosis. And we will now follow to the topic stigma and therapeutic relationships analyzed from the perspective of mental health service users. The paradigm shift from a paternalistic model to one that respects the person's autonomy has led to professionals accepting an active role of the healthcare service users, making decisions that can affect their health. But in Spain, we have a Mediterranean culture, and it is quite a paternalistic one. And we wanted to know how was the therapeutic relationship from the perspective of the people we care for. So we developed an emancipatory research study using focus groups with persons who had a diagnosed mental disorder and experiences with different healthcare services. I mean, not only mental health. What did they tell us? Our conclusions were that health professionals, as we knew, are not exempt from prejudice. The experience of abuse of power, malpractice, and over-medication to be heard, but they were heard in these focus groups. Professionals' attitudes, if you are suffering experience of abuse, obviously this is a huge barrier for therapeutic alliance. And people with a psychiatric diagnosis do not feel involved in making decisions. Sometimes they even reported that they went to, for example, they went to a cardiologist in company of a relative, and the cardiologist was talking only to the father or the mother of the caregiver who was going with them. And they felt like ignored, and anything they said had to be double checked, and they did not feel any well about that. So knowing how they perceive the interactions we have, can give us some keys to change this. The second study regarding therapeutic relationship most directly, as you will see there are some later, was a lived experience. A lived experience precisely by a mental health nurse who was very concerned by therapeutic relationships. She had a bad experience when she had an admission to a psychiatric care acute unit, and also during her period she had a follow-up. We explored, we told the experience of a mental health nurse since her first psychotic symptoms, and she explained that mental health professionals often do not detect, or sometimes maybe do not want to detect, the feelings and the perceptions that the person has, and this leads to a dehumanization of care. This nurse even told us that she felt she was completely blocked and she could not speak, but she heard how the nurses were talking badly about her, and this did not help her even to interpret what was happening, or to improve, or to feel understood. So this was a very bad experience for this nurse. After these two studies, in which we explored directly the therapeutic relationships from the user's point of view, we moved to one cause and also a consequence of stigma, which is coercion. To start with, when we wanted to start to research about coercion, we found that there was already a lot of information about it. In fact, we found there were so many systematic reviews that to have a scope of how the field was, we had to do an umbrella review. We analyzed 46 systematic reviews and meta-analysis, and also including meta-synthesis, in which the central theme was coercion. We divided the topics into two main categories. We have, on the one hand, evidence on specific coercive formal measures, mostly formal. The most prevalent one was physical restraint. And this evidence we found was related to prevalence, or to related factors, effectiveness, harmful effects, or even there are ways to reduce it. And on the other hand, we found the experiences. The meta-synthesis provided us with the experiences, perceptions, and attitudes concerning coercion of professionals, of people who had been suffering coercion, or their caregivers or relatives. In this umbrella review, we found that there was a gap in knowledge regarding coercion and inpatient rehabilitation units, which are relatively common in Spain. So we found that this gap of knowledge was affected both the user's perception and the professional's perception. So we developed one qualitative and one mixed methods study to know what was the experience of coercion among nursing professionals. For professionals, we recruited nursing staff who were willing to participate and who were working at the inpatient rehabilitation unit. And we made 28 interviews, face-to-face interviews following a semi-structured script. And we found two main things. The first one was the therapeutic relationship itself. We were not exploring how it was for them, but we found that it was very related to how coercion was perceived by them. So we included this thing. The professionals highlighted the necessary attitudes and the necessary qualities that nurses or care assistants needed to build an appropriate care relationship. And the perceptions about, well, another theme was the sub-theme was the perceptions of they had of the persons they care for. We found some very stigmatizing visions, and also other who were neutral or even positive or neutral. Views of the therapeutic relationship was another of the themes we found. And then the second theme was obviously coercion. Regarding knowledge that the professionals had, it surprised us that 8 participants did not know what coercion meant. Working for years in an institution that can apply coercion. Professional knowledge was this theme, general aspects, emotional impact for them of coercion, for the professionals, opinions they had, and also how they thought it could be reduced. But mainly what we found was that coercive measures are normalized, are accepted, and considered implicit or a necessary evil in daily practice. Then we moved to the study with persons who were admitted to the unit, and knowing that coercion influences the experience and can also influence the recovery process, we wanted to understand how it was perceived. And in this case, we chose a mixed method study in which we planned interviews, semi-structured interviews, but also quantitative measurements with the coercion experience scale that has been recently validated in the Spanish context. So we had 75 participants in the quantitative branch and 20 participants in the qualitative branch of the study. And we found two main themes. The first was the treatment received, the interpersonal treatment, not the drugs, in the unit. They were divided basically into good treatment versus unfair treatment. And regarding the experience of coercion the participants expressed, some of them talked about feeling a lack of freedom, and others expressed that it was too lax. That some they say they felt they were in a hotel. Some said they were feeling in a prison. Also, they talked about formal and informal coercive measures and the positive or negative impact of the roles in the unit. Some of them found them strictly necessary. Other ones found that they were simply obstructions to recovery. And the quantitative branch of the study, we obtained that the coercion perceived was very low. And this is normal because in this unit, formal coercion measures, which are the ones that this scale measures, are not mostly applied. I mean, in 3 years that lasted the study, only one person had to be physically restrained for 1 hour. So it's very low. The participants' views informed us of different perceptions of what it means to be well treated. And what they all agreed on was the need to feel respected, of course, and the importance of communication management by professionals. And also, it was relevant that informal coercion was very frequent, the most frequent. It's all over in psychiatric practice, but the participants were often unaware that it was coercion. They said that they felt there were attitudes that the professionals held for beneficence, for promoting their own good. So they didn't feel that it was coercion at all. And considering these findings related to physical health, therapeutic relationship, and also coercion, we also studied a way, or one way, to reduce stigma. And we decided to start from the very beginning, students. With stigma and students, since 2007, we were offering to our students a direct contact intervention that was designed then. In 2007, but several years later, we decided that we wanted to measure the effectiveness it had on the attitudes that students show. So we designed a quasi-experimental study in which every participant was their own control with the pre-test, post-test measures. And we did the pre-test after the students have done their theory in mental health nursing subject. Then they received the direct contact intervention, and 15 days later, they received the post-test assessment. The direct contact intervention consists of a 90-minute session following a structured script provided by persons with lived experience. One person with lived experience as a mental health service user, and another one as a relative or caregiver. And they give us their experience of recovery. And they give us also the importance that nurses and other health professionals had in the recovery process. What we found in this study was that the questionnaire that we used was a mental illness stigma attribution questionnaire by Corrigan et al., IQ27, the Spanish form. It gave improvements in most of the areas. It decreased fear, feelings of danger, avoidance, segregation, and coercive attitudes, And there were increases in the tendency to help and the compassion. So we found that this was useful, and we decided that this could be expanded to other areas of education. Precisely, we moved this to vocational students of health sciences and social sciences. And we did this not only thinking about their professional future, but also thinking about according to the World Health Organization, half of mental health problems start in adolescence. And stigma is one of the main barriers for adolescents or young people to look for help. So we applied this direct contact intervention, and in this case, we had a sample of 128 participants from 3 different vocational schools. And considered all together, we measured differences in the AQ27 and also the community attitudes toward mental health, the CAMI. And we found that there were improvements, statistically significant improvements in 11 of the 13 dimensions. And we also found that this intervention is not for everyone. The students under 18 did not benefit from this intervention, but people who were 20 to 80 were the main group, they improved. So these are the pieces of research related to stigma that I wanted to share with you. Now let's move to the conclusions and the future developments. The main conclusions are that people treated with long-acting injectable antipsychotics had an increased risk of cardiovascular risk, and also had higher prevention of sexual dysfunction. Women with a psychiatric diagnosis who were admitted to a hospital had lower levels, very, very lower levels of cervical cancer screening rates. Individuals with a psychiatric diagnosis had 4 times the risk of being diagnosed with an advanced stage cancer. Persons with psychiatric diagnosis do not feel involved in making decisions about their own health. Health professionals are not exempt from prejudice and can dehumanize care. Professionals can normalize and consider coercive measures implicit to daily practice, and direct contact interventions are effective in reducing stigma among adult students. What are the future developments? What are we working in at the moment? We are developing a validation of a scale for stigma. We are also expanding the direct contact interventions to other degrees at university, for example, psychology or social work, and also to other branches of vocational students. We are designing a multimodal psychoeducation and exercise program for people treated with long-acting injectable antipsychotics. We are doing interventions to improve the professionals' literacy, awareness, and attitudes towards stigma and coercion. And we are also developing a PhD thesis on informal coercion with the aim to develop a scale to measure informal coercion, which is the most unknown and the most prevalent. So we are very interested in it. And this brings me to the end of my presentation. I would now be interested in hearing any comments or questions. I thank you all for your time and for listening to my presentation. Thank you for having me.
Thank you, Vanessa. I may have missed this, but could you just explain what informal coercion is?
Informal coercion is, well, first we have to explain what is formal coercion. Formal coercion is the one that is legally regulated. That is involuntary treatment, involuntary admission, physical restraint, and community treatment orders. These are the formal measures. Anything else in which we push somebody to decide something they don't want to, we are doing informal coercion.
Okay, thanks.
Thank you for the question, because I was talking about it and I have not explained.
No, I've just not heard that. I see the distinction, and I think you're right. It's a lot about, for example, in the broader area of discrimination, there are behaviors that are proscribed, but there are those as well that are subtle and are not, necessarily things that you can take to court, but which affect you in a day-to-day way. For example, the behavior of moving away from you in a shop or refusing to serve you in the order that you are. This is a very common experience associated with race, but that's not easy to measure objectively, and therefore I can see what you're talking. I understand now what you mean by informal coercion. I wondered to what extent, one of the things I remember one of my colleagues who does a lot of work in stigma and discrimination once telling me that what really matters is discrimination and not stigma. And let me explain. Let me clarify what he meant. What he meant is this: that I cannot force you to love me, but it is intolerable for you to discriminate against me. So, for example, if I'm talking about a person with serious mental illness living as my neighbor, I don't have to love that person, call them over for tea, or make friends with them, but I cannot stop them from living next to me. Do you see what I mean?
Yes.
So it's the behavior that really matters.
What we see.
Yeah, because that's what the other person, of course, you also experience stigma, but it's the behavior that hurts. Actions and deeds hurt more than thoughts. And I wonder to what extent, that's why it's always stigma and discrimination, right? If you look at many of the ways we talk about this. I wonder to what extent do the interventions you describe, do you plan to actually address discriminatory behavior rather than just attitudes? And just to give you a very good example of this is the relationship between knowledge and behavior is weak at best. Most people who smoke, for example, it's not that they're not aware that smoking is harmful, not at all. In fact, almost there's no relationship between the knowledge of smoking and smoking behavior. So in a way, what I'm trying to get at is, of course, attitudes and knowledge are important, but they in and of themselves don't necessarily predict behavior.
Yeah, that is why we were measuring the consequences of this behavior of professionals, like ignoring that. We have been reading a lot, and some professionals do not derive people who have a mental diagnosis to specialists because they think they will not go, or the red flag in your file that shows that if you have anxiety and you have back pain, probably that back pain will be attributed to your anxiety.
Mm-hmm.
That those are the discriminant behaviors. But we don't have a scale to measure the behaviors, only the consequences of them. Mm-hmm. But we can measure the attitudes, and that's why we worked measuring attitudes, expecting that they could modify the behaviors, which is in the end the coercion, and also the ignoring. The sexual dysfunction was people were frustrated because they said nobody cares about this. Independent of the age, they said women were more indifferent actually at certain ages, but men were very concerned that professionals were not worried about their sexual life.
Yeah,
and this is the behavior what the persons find in the attention they receive.
So one way of actually possibly measuring behavior is not by asking the provider, but by asking the patient.
Yes.
So for example, in an inpatient unit, such as the ones you work in, that you randomize or you do a pre-post, and you sort of before your intervention, you ask a representative section of patients about specific behaviors that they have experienced from the staff, including involuntary, both formal and informal. And then you repeat that after your intervention and look at whether your prevalence reduces. That's one way, because you can't ask people,
no,
were you discriminatory? I mean, no one's going to say yes.
You have the option to observe, but that is not very welcome. And
an observation comes with bias.
Yeah.
It's very, very hard to behave badly when someone's watching you. It's not impossible, but there's a bias there, obvious bias.
What you're going to find there is paternalistic attitudes exhibited more than anything, because who is paternalistic? Those who are paternalistic, they don't know. So they will act like protecting or infantilizing, or these things happen in clinical practice as well. I have no mention.
We can just hear it. I'm going to say take down the slide so we can see the screen.
It's on Vanessa's.
Oh, okay.
Oh, so but I can.
No. Just stop sharing the presentation. Then we can see.
I don't think anyone has their camera.
Oh, okay, all right. Okay, so let's invite more questions or comments for Vanessa.
Thank you. So in your first study, when you were describing the low rates of cervical cancer screenings, I don't know if it was part of the research question, but why was that? I guess my question is, was it really because people didn't want to go in, either because maybe they didn't know to, if they were having a lot of severe mental health symptoms, or they didn't know how to, Or was it because they were going in and it just wasn't being recognized by providers as something that needed to be done? Like on where was the issue originating?
We didn't actually research that because we were, what we did was collecting the women's data by what they reported verbally and also by their medical records. And this is multi-causal, as you were saying. One of the causes is that at that time, cervical cancer screening was not mass population screening, it was opportunistic. So what happens if a woman without a psychiatric diagnosis attends a midwife or attends a nurse for another reason, she will be directed or derived to have a cervical cancer screening. But this doesn't happen with women who have a mental disorder, or they do not have the calendar controlling when is the next day they have to. So it's multi-causal. Yeah. Thank you very much for your question. Isaac?
Niharika, Isaac, did you have your hand up? I couldn't see.
Yes.
Yeah, Niharika, Isaac, and Mary.
Thank you for your presentation. It's very interesting, and I found the qualitative aspects of it really helpful to hear about. Something I hear from care providers a lot, and when maybe justifying some of coercive behaviors, is that with psychosis, there's often a lack of insight that one has into their own condition, and that is something that I hear that they use to justify this coercion. So I guess, did that come up in your studies, and what would your response to that be?
What we found mostly among professionals was they were looking for beneficence and acting for the own good of the person they were caring for, not knowing that they were forcing them to make decisions they did not want to.
Yeah.
I don't know if I'm asking your question.
Yeah, kind of. I guess the way they justify it is saying that they are not able to make these decisions. So yeah, makes sense.
Yeah, they lose autonomy. We remove them their autonomy because we consider that they cannot decide, or we decide better for them than they do by themselves. So, yes.
That makes sense. They are well intentioned, but
Yeah, that's it.
not
And
good enough.
the fact that 8 out of 28 did not know what coercion was gives you much information about that.
Totally. Yeah, thank you.
Thanks to you. Isaac.
No, thank you for your presentation, Vanessa. I was so excited to see that some of your studies were with lived experience populations. I was very curious if through our own research, we see varying definitions of lived experience, whether it's a formal diagnosis or just a self identification. So I guess, how did you all in those two different studies define lived experience, and also kind of
The fact was that we were collecting people, recruiting people from self-help groups. So they had previously received a psychiatric diagnosis, and they were in the recovery process. And about this thing, and comparing to the peer movement here in the United States, in Spain, these groups are very dark and unknown for professionals. So what we need to know is what do self-help care groups do as professionals to understand and support them from the outside. But there is resistance or and not knowing, but yeah, it's something we professionals should study about. And this is probably one of the lines that I will start working in with some colleagues when I go back to Spain. Yeah, trying to join the forces of live support experience and professionals as an external support, or even collaborating, as you have to do here, which is great.
Yeah, and then if I could ask a second question regarding the study that was the short intervention for students particularly, were any of the students involved in the actual development of the intervention, or was it a pre-existing intervention that you developed?
It was a pre-existing intervention. There, we collaborate with an organization that has at the moment 1,000 associated people. One per family, there can be only one member. And there is a group in this organization who work against stigma. There's a subgroup of fighting stigma. And they prepare their recovery stories to share with the students. And we never know who's going to come to give the directing, to provide the direct intervention for students because they do it according to their agenda. So it's not very rigid script, but every participant gives their own recovery experience. But students do not participate. No, they only receive it like a real life example of what they have been studying, seeing it when a person is recovered. Like, you don't always have to think that a person who has had a psychotic disorder or has had a psychotic episode is always like that. This is what you see, a person just like you.
Thank you.
Thanks to you.
Very
I just had a question. So, was your work in the context of severe mental illness, the coercion study and the student study? Was this in the context of severe mental illness? Like, for example, in the coercion study, you interviewed nurses who are working in inpatient units. So I'm assuming it is for severe mental illness of patients who had a severe diagnosis, or did this also include mild to moderate forms of depression, etc.?
Thank you very much, Mary. We have in the rehabilitation unit, I was talking to you about, there are admitted people who are considered treatment resistant.
Okay.
So they are admitted and they live in the hospital for a period of around 9 months as a mean time. And they can have very different diagnoses. Some people have a personality disorder and they are there. They are treated maybe with or without drugs, but they are there to do some psychoeducation and learn to live with their disorders. Most people have bipolar disorder or schizophrenia disorders, but some of them are. We didn't have for the coercion study. We did not consider only person who covered the severe mental illness criterion.
The other thing is just a comment. So I'm part of this network is called the
You need to
Global.
speak a little louder, Mary. The
sorry.
people at the back
And
there.
I cannot
Sorry.
I get closer.
The other one is just a comment. So I'm part of this network called the Global Mental Health Action Network. And we have a stigma and discrimination working group. And in fact, on Monday, we have a session about contact-based approaches to tackle stigma. So
Wow.
I can send you an invite and anyone else who's interested, and you can join.
Please, yes. Thank you very much. Thank you.
Tashika?
Yeah, so my question was actually a follow-up on Niharika's question. So you said like patients who were treated with long-acting injectable antipsychotics had more sexual dysfunction problems and then they were stigmatized. So in that case, would it be like informal coercion, like a physician deciding that it is important for the patient to take antipsychotics and deal with sexual dysfunction and like not label that as informal coercion and it's just like for the benefit of the patient, or do we still label that as coercion and solve that problem? Isn't it just?
It's even worse, Ashika, because some of the persons were involuntarily treated. They had an order to be treated, and they went there. They were willing to participate in the studies, I have to say, but they were not willing to have these drugs, and so it was formal coercion directly, not informal even.
Okay.
Like some of the persons complained and some got medication changes. As you know, not all the antipsychotics are related to sexual dysfunction as well, but some didn't receive the change because either they were pressed either by the families that, oh, no, now you're stable, this is the main problem, sexual life is not so important as your general well-being. That was the family coercion. And then the professionals, when they find the balance, they think they have found the balance, they don't want to change. So that's, but it's formal coercion, really. Thank you.
So I wanted you to, so you had a question?
Sure.
No, please.
I actually have just 2 comments. I think you've done a really good job on summarizing papers on a slide. That was so much information, but so condensely produced, so that's nice.
Sorry about that.
No, it's really good actually. I like it. But my quick comment is the therapeutic relationship / alliance you mentioned, that really resonates with me when we talk to so many of our psychiatrist friends. I don't know if there is a psychiatrist in the room.
There's at least one. Don't target me.
This is coming up, and as you will hear in my talk as well, what do you mean therapeutic relationship. It's a drug, antipsychotic, and you go home or whatever, right?
Bio.
Yeah, it's exactly. So it's so closely resonating with me at least, and it's such an important thing. But I don't think it's fully talked about in the academic discourse in psychiatric conferences. I don't think so, and there needs to be more discussion about it.
You hear this much more in conferences of psychologists, especially,
nurses.
sorry, and
And
nursing, of
nurses.
course, sorry.
Yeah.
The problem, you're right, sorry, no, I would say all the non-prescribing,
Yes.
which is pretty much everyone other than psychiatrists, because of course they're social workers and so on. So, and I think it has to do with the assumptions of what drives recovery. And those assumptions are very different for different professional groups. It's a problem in our field of mental health. You do not see this in other areas of medicine where no matter what your background is professionally, you share a set of common ideas about disease processes and therefore the therapeutic processes. In mental health, because we don't actually have any disease or any clear-cut processes that are proven, each professional group embraces their own view of what that disease process is. So psychiatrists will use a very chemical theory, even though there's no proof of any of it. And so that then justifies what matters is like the same way that you treat malaria with a set of pills. There's no therapeutic alliance in malaria. You just give the set of pills and say, just take those pills. Whereas a social worker, for example, and we have one right here, so she can speak about that. Those processes, Laura, I mean, how does social
I'll
work?
have to say, I don't necessarily have ever worked as a social worker, but my PhD was in social work research. But yeah, then that thought process is like the human and environment, and they're trained to look at all of the, I mean, actually, it's really social determinants of health focused, I would say, where they're looking at all these external factors and then say how that would be their theory of change for why someone is like either thinking, feeling, or behaving the way that they are.
And what about nurses? When nurses are trained about the causation of mental health problems, what usually what is a dominant theoretical paradigm of mental illness?
Biopsychosocial.
Yeah.
But we rely on brain chemistry to explain it also. The paradigm we try to follow at the moment is the recovery, but this is starting from the academia and then it will go to clinical practice, hopefully. But yeah, biopsychosocial. And we accept that there is a chemical change in brain, but what has caused it? What's the bank that starts the chemical from not working? That's where we are rely on the social and the psycho. There's even in Spain, there was a program that tried to start several years ago that was job prescribing, like social prescribing or job prescribing to show that the social component is so important for recovery and also to prevent recovery and prevention. So multi-component, but
yeah, social prescribing is an interesting idea as well, which I have been reading more about. And the notion that you can actually apply a biomedical model, because prescription is such a biomedical act, but you can apply it for things like housing, work, and on the basis that these are actually mechanistically directly associated with shaping our mental health. And so again, this is the sort of thing you'd never see happening in a medical clinic. But if you had a comprehensive service where all of these different needs are met in a person-centered way, then I would imagine for many people with mental health problems, the social world would probably rank number one on the things that they would like to see fixed. Yeah. Sure. One of the things that's interesting here, my knowledge of social contact interventions has always been in the context of people who are working outside the mental health sector, because the idea here is that when you're living in a community or working in a school or even primary care, you're not obviously aware of who has a mental health problem, and your attitudes towards mental illness are shaped by movies and by what you read, and of course just by plain more prejudice. What is ironic is you're describing social contact interventions for people who work every single day with people who are explicitly living with a mental illness, because they're mental health practitioners.
Well, they're students. They don't.
Oh, I
they
see. I
haven't
thought you
started
said there
yet.
was also something on the wards.
We're working on that,
Yeah,
on
yeah.
how we will.
But I'd be curious to see how do you do a social contact intervention with people who are in social contact with people with mental illness every day?
It can be interesting, for example, for professionals who work in acute care, they imagine that the life of a person who has been admitted continues to be in the worst moment of their lives as when they had been admitted. So
Got it.
when they are recovered,
Yeah.
if you meet them again, it's like, are you the same person? And you're surprised or they are surprised, we are surprised because we have the idea that their life is always as when they were admitted. And direct contact intervention for hospital workers, at least, might work. Not so much for community workers, because community mental health workers, they see their persons evolve and change and recover. But for persons in acute care units, I think it would be very good, and it is one of the places where stigma is worse. Because
Yeah,
of
that's
that,
a great
because they
observation.
don't see the full life of the person. They only see that moment, and they believe that that is their life. So that is their life. Thank you very much.
Okay, well, thank you very
Thank
much,
you.
Vanessa.